Thank you. So good evening and welcome to our presentation, Cancer and Sexuality. I'm Joan Hogan, Oncology Social Work Manager at the Rutgers Cancer Institute of New Jersey. As everyone will be on mute during the presentation, please type any questions you may have into the chat box. They will be addressed at the end of the program. Next slide. So our program will be broken down into 3 sections. The social work team will be discussing the emotional aspects of cancer relating to intimacy and sexuality, followed by Valerie Shander, nurse practitioner, who will speak about women and sexuality and the side effects of treatment. And then we will conclude with Dr. Velez addressing issues men may experience when undergoing cancer treatment. So let's begin. Next slide, please.
Hi, I'm Rose Lizeski. I'm one of the social workers here. So intimacy and sexuality. So cancer and cancer treatment, including surgery, radiation treatment, chemotherapy, immunotherapy, and other modalities can impact not only your physical health, but also your emotional health and body image, which may be impacted by loss of hair, fluctuation in weight, surgical scars, or uncertainty regarding bowel movements, incontinence, things like that. Okay, so physical changes that may occur due to chemotherapy and any other treatment modalities. And this is not an exhaustive list, but it may include pain, sensitivity, numbness, changes in sensation, challenges with mobility, concerns about ostomies, nephrostomy tubes, ports, or other medical devices, chronic fatigue, weakness, shortness of breath, and or reduced stamina. Women may experience early menopause, vaginal dryness, or other symptoms. Men may experience erectile dysfunction and other associated symptoms. Both men and women may experience a lack of desire to be sexually intimate and or hormonal changes that could include hot flashes, fatigue, decreased libido due to cancer treatment or other medications they're taking, but also decreased libido may have an emotional component. And an increase in risk of infection is also something that both men and women may experience. And there may also be difficulty in becoming aroused or reaching orgasm. Emotional changes may include depression, sadness, anxiety, increased vulnerability. Any of the aforementioned changes, any of the changes here on this slide may affect feelings of desirability and make being intimate or experiencing pleasure difficult. Next slide, please.
My name's Gabrielle, and I'm going to talk a little more about the emotional, social, and psychological impact of a cancer diagnosis. So as we know, cancer does not always affect individuals physically, but emotionally as well. And this emotional impact can in turn impact your experience with sex and intimacy. So some of the emotional, social, and psychological impacts of a cancer diagnosis can include things like altered body image. When you undergo some of those physical changes, as Rose previously mentioned, it's likely to be a really difficult adjustment for you emotionally as well, because in a way you are kind of grieving the old parts of you and learning to adjust to the new parts of you. This may cause you to not quite feel like yourself, which is an emotional, just very emotionally difficult. It can also cause some fears about being intimate with your partner. Fears may include things like being worried that intercourse will be painful or that chemotherapeutic changes may do harm to your partner or to you. So these are all important questions to discuss with your medical team. And I think some of the medical staff members we have on today will talk about that a little bit more later on. You might also face concerns about your sexual performance. Because your body has underwent so many changes, sex may look a little bit different now. So it's important to know that this is a normal experience and something just to work through and communicate with your partner. There may be some concerns about rejection from your partner, and this may bring up some friction in your relationship, which is normal as well. But seeking out individual or couples counseling may be helpful through this transition. And lastly, you might not have a desire to be intimate during this time, and that's okay. Give yourself a little bit of grace. You're juggling a lot right now, so take it one day at a time. Other things to consider is that sex and intimacy may longer seem super important to you. With a cancer diagnosis, you are juggling a lot of things, and sex might not be the first thing on your mind. For some, undergoing sperm banking and egg preservation may be a part of your cancer journey, and that will be discussed a little bit later on as well. Along with the potential need to refrain from intercourse while you're undergoing treatment. Should this be the case for you, you can discuss with your partner and your medical team other ways that you might be able to be intimate or show affection to your partner through this time. But communication is really essential. And I think we'll discuss that more on the next slide. So just something you could go to the next slide, please. Thank you.
Yeah, Gabrielle.
Okay, apologies. Hi, I'm Gabrielle Shander, and communication with your healthcare team before, during, and after treatment is essential when it comes to your sexual health. Patients are encouraged to ask questions and voice their concerns. They should never feel rushed or embarrassed when having these types of discussions with their healthcare team. And patients are encouraged to communicate the gender of their partner or potential partner, as this may impact medical recommendations. Communication with your partner about your fears, sense of loss, and concerns regarding your relationship may be difficult. So some tips are as follows: choosing a time and a place when you and your partner are relaxed and have time to discuss mutual feelings. Honestly discuss practices that feel good and ones that don't. Talk about creative ways to experience sexual pleasure that may not involve penetration, and be gentle with yourself and proceed at a pace that is comfortable for you. Next slide, please.
Hi, my name is Deborah. I'm going to talk about options for emotional support while you're going through this. This topic is a difficult one for people to talk about. And so what you may need is some support in how to have these conversations. So professional counselors and clinical social workers can help provide guidance and language to make intimate conversations easier and more productive. So because these conversations are very difficult, what we recommend or suggest is that if you have someone who you can voice how you're feeling and you're not sure how to voice that to your partner, then having someone who is professionally trained talk about this would be very beneficial. They can also validate your feelings and help provide emotional support, provide educational resources that are reliable and professional, websites or lists of reading materials and information on products such as lubricants and dilators, all of things that you may not think to talk about with your medical team. This would be someone who could help you with preparing for visits with the doctors, and they even may be able to collaborate with your healthcare team to integrate the mental health therapies into your care plan for your cancer treatment. Next slide.
Okay. And then just to wrap up our portion of the presentation, just some considerations and suggestions and things to think about when thinking about your sexual health and intimacy. To always check with your healthcare provider to see if any medications that you're taking might be affecting your sexual health. You know, having that knowledge is important, because then you can parse out, you know, what is a medication side effect or things like that. And then what, you know, is the emotional piece as well. And then making sure that you're making self-care a priority in whatever that looks like for you. Maybe that's meditating daily, or journaling or doing something that you enjoy, like a craft, or making sure that you're exercising or going on walks. Something else is really maintaining a schedule that is realistic and allows times for socialization and partner engagement. And that might sound really simple, but planning a time to be to connect with your partner, you know, having a plan, time set aside, intentional time, can be really helpful, whether that is to communicate, you know, just to communicate, be in each other's space, or to be intimate, but just to really set that time aside for yourself. And then finally, just remembering to take it one step at a time, you know, and remembering to breathe, and that there are supports available to you, you know, as you're going through this transition and this process. Okay. Thank you. Next presentation.
Hi, so I'm Valerie Shander. I'm a nurse practitioner. I've been in oncology since 2013 with a special focus on medical breast oncology along with GYN oncology. So those are the two areas of practice. Next slide. So women's sexual dysfunction is defined as persistent or recurrent trouble accessing.
Valerie?
Yes?
I'm so sorry. I'm just having a little trouble hearing you. I don't know if anyone else is having the breakup.
Anyone having trouble?
It's
That's
a little
much better.
Yeah, that's much better now.
Need to lean forward, sorry. So women's sexual dysfunction is defined as persistent or recurrent trouble accessing and completing one or more phases of physical sexual response. So there's 4 phases of sexuality: desire, arousal, and orgasm, and resolution. Still having trouble hearing?
Valerie, I
People
find that when you're leaning forward a little more, I can hear a little bit better. I don't know if anyone else is experiencing that.
Yes.
All right, sorry. So women's sexual arousal is complex. There's many drivers to women's sexual needs. One is anxiety and depression can affect a woman's sexual arousal, primarily if the woman's self-blames herself for her cancer, her previous behaviors, her transgressions. It can also be limited by physical changes such as surgeries, lumpectomy, vasectomy, ostomies. Other comorbid diseases can also cause limitations, along with medications that can affect sexuality. So always be discussing side effects of the medications, including those that treat depression. And those that are relationships that are already negative to begin with going into a cancer diagnosis then get worse with treatment and cancer, and therefore affect a woman's arousal. Next slide.
And
Valerie, we're having a problem again.
Yeah,
The sound is.
Sorry. One. Next slide. So side effects of treatment. Patients can acquire sexual side effects from many different sources. It can be from chemotherapy, immunotherapy, target therapies, radiation, surgery, and aromatase inhibitors, which are medications we often give for breast cancer or GYN cancers. They can be temporary side effects or they can be long-term, depending on what treatment and what things are happening. One study showed that sexual dysfunction in women with cancers can range from 30 to 80%. The most common cancers associated with sexual dysfunction include cervical, breast, and endometrial cancers. And the most common side effects are reduced desire, arousal, and orgasm. Next slide. So you can have multiple different surgeries for cancer that can affect one's sexuality. So one can be surgeries on the breast, such as a mastectomy or lumpectomy, with or without reconstruction. It can change a woman's way she views herself and the way that she feels sexual desire or feels that her partner may find her sexually desirable. Also, you can have ostomy, which is a way of having your bowels or bladder be released from externally. And that may change your way of being able to be in certain positions or how you view yourself again, or you may just be uncomfortable being naked based on having those things. Patients can have hysterectomies, can have short-term and long-term side effects from the hysterectomy. Especially if a woman has a radical hysterectomy, she's more likely to have more significant, more strong side effects. Short-term side effects from a hysterectomy can be orgasmic difficulties, sexual dissatisfaction, can also have decreased vaginal size during intercourse, and which may cause more distress. Long-term side effects can be decreased libido and decreased vaginal lubrication. Next slide. Other things that can happen, you can suppress ovaries. This can be done either through surgery by removing the ovaries, or it can be done with medication. Sometimes we give patients medications to induce menopause and therefore cause more side effects to them, such as atrophic changes to the vagina and the clitoris, vaginal thinning, decreased elasticity of the vagina, and overall dryness, which then will decrease their desire and their interest in intercourse. Next slide. Chemotherapy can very much affect a person's self-image, especially if you're having alopecia, hair loss, or generalized weakness. It can also decrease your sexual interest if you're really exhausted from chemotherapy or you're having significant anemia. If you're having horrible diarrhea, no one wants to be sexually active. So all those things can really affect your desire and your interest. In a premenopausal woman, we often will induce menopause. Sometimes it will be a permanent induction of menopause. Sometimes it will be a temporary induction of menopause, depending on where they are in their life cycle. If they are a later 40-year-old woman, they may be induced into permanent menopause, versus someone in their 20s may just have a temporary menopause. But either way, they will have menopausal symptoms and therefore will not have as much of a desire and as much vaginal lubrication. Next slide. Anti-estrogen therapies are often used. They can be used in breast cancer patients and they can be used in GYN cancer patients at times. They're for patients who have estrogen positive cancers, and we may give them tamoxifen, Arimidex, which is also named as anastrozole, letrozole, Femara, aromacin, or exemestane. These can cause sexual side effects. People will often have impaired vaginal congestion. Hot flashes can be very common, which again decreases people's desire to be sexually active. People's libido can be decreased. Tamoxifen is notorious for causing weight gain, which then will affect people's body images. And lack of vaginal lubrication can affect arousal and pain and cause pain issues. Next slide. Radiation, especially if you're giving radiation to the pelvic area, can really cause a lot of fibrosis and stenosis, which then makes sexual dysfunction occur and oftentimes a lot of pain. It also will increase the risk of infertility, along with cause poor pregnancy outcomes if people are still of childbearing ages. If the ovaries are radiated, it can also cause increased risk of sterilization and early menopause. So one way, if patients are keeping their ovaries but removing their uterus and they're still of childbearing ages, the surgeon will oftentimes raise their ovaries out of the radiation field, so this will not occur. Next slide. This is a diagram of on the left side, a woman who has not had any menopausal changes or chemotherapy-induced menopausal changes, or radiation changes, I'm sorry. On the right side, it is someone who has experienced those changes. So you can see her vagina is a little bit shorter. It's a little bit thinner compared to the left side. There's also decreased elasticity, which is harder to see. And there's also increased vaginal dryness on that right side. Next slide. Estrogen replacement. A lot of patients will want estrogen replacement because they will help with their hot flashes. It will help with vaginal dryness and decreased libido, but we often will not prescribe these estrogen replacements. The reason being, especially if your cancer feeds off of estrogen, we give you an estrogen replacement, it will give fuel to your cancer. And even if there's no evidence of your cancer at the time, it can cause growth and reoccurrence along with metastatic disease. So we often will not give oral estrogen replacements. It also can increase your risk for blood clots or strokes. And if you have an active cancer, this is already putting you at increased risk for clots. If you have a cancer that's in remission, you're not as much at risk for clots, but if you have an active disease, that does put you at risk. Next slide. So there are many treatments for hot flashes. We can treat hot flashes whether you're in early menopause, later menopause, either way we can treat hot flashes. Some ways of treating hot flashes have been shown to be decreasing stress, which I know is easier said than done for all of us. But some ways you can do that is with relaxation, paced breathing, acupuncture. Hypnosis has been shown to be a very good way of decreasing stress and helping with hot flashes. One study I saw showed that over 58% of patients who've done hypnosis have had significant improvement of their hot flashes. So it is a good tool. You just have to find someone you're comfortable doing hypnosis with you. Other things is avoiding triggers. Alcohol, spicy foods, and caffeine can all trigger hot flashes. So you may still want to choose to have those things, but being aware and making a conscious decision that those are going to trigger your hot flashes and being aware that that can occur. So maybe deciding to have that hot flash because you really want that alcohol, but knowing that that's what you're doing so you can make more informed decision. Dressing in layers, cotton clothing, and bedding, along with using cooling aids, all help to reduce hot flashes. There are also medications that we use. One is a low-dose antidepressant called Effexor or venlafaxine, which has been shown to help with hot flashes, along with helping with depression and anxiety. And it's generally well tolerated, especially in the very low dose that we often will prescribe to patients. It doesn't have any hormones, so it doesn't cause any increased risk for cancer reoccurrence. We also sometimes will use Celexa, oxybutynin, gabapentin, or clonidine. If you are having severe hot flashes, you need to discuss it with your provider to see if a change to your agent will be. Sometimes by switching medications within the class that you're in can really significantly improve your hot flashes. Next slide. So this is just a funny little slide that I thought. Next slide. So treatment of vaginal dryness. There are natural ways of treating vaginal dryness with using coconut oil. It has no hormones, it's safe to use, and it's well tolerated and really does help with vaginal dryness. In some cases, we can use estrogen cream, which can be prescribed 2 to 3 times a week and applied directly to the vaginal mucosa. By using a vaginal cream for estrogen, it is less systemic, so we're not getting the side effects throughout our whole body of the estrogen, but still getting the benefit with giving increased lubrication to our vagina. Lubricants can be used. They're used with intercourse, and moisturizers can be used nightly to add moisture to the vagina. Next slide. So the difference between lubricants and moisturizers. Lubricants are more water-based. You should make sure they don't have any perfumes, any coloring, spermicides, herbal remedies, or flavors. Those can all irritate the genitalia tissue. Warming gels can also cause burning, so making sure you don't use those. Petroleum jelly, skin lotions, and other oil-based lubricants are not good choices. They can increase your risk for a yeast infection. And making sure that if you're using a latex condom, don't use petroleum products because those can cause damage to the condom, thereby making it ineffective. Making sure that you avoid any gels or condoms with N9 in them. This can irritate the vagina, which then can cause more dryness and more fragility, which then can cause more irritation. Lubricants are used during sexual intercourse. If you do perform sexual activity longer than a couple of minutes, you need to reapply lubricant, otherwise it will stop working. You want to put the lubricant around the inside of the entrance of the vagina, also applied to the partner's penis, finger, or their other insert. Moisturizers are used daily to several times a week. They last longer than during sexual activity, but they need to be, and they don't need to be done during intercourse. You don't want to be doing them during intercourse, in fact. It helps to add moisture to the vagina and make the pH more normalized. Next slide. Vaginal laser therapy is something I'm not really well versed on, but I did see it when I was researching for this talk. It is something that is using fractional microablative carbon dioxide lasers to help treat the vaginal dryness and dyspareunia in female cancer survivors with vaginal atrophy. But the safety and efficacy is undetermined. So don't go forward with it. There's no research really on it. It's not safe, but I put it in there just in case people have heard about it. Next slide. Vaginal estrogens. They're used to treat vaginal atrophy. Again, it is safer because it is just localized to your vagina. You're not getting the systemic effects of it, so it's not causing the increased risk for cancer reoccurrence. So we do oftentimes, if we have a patient with a lot of vaginal dryness and issues with intercourse because of that, we can sometimes prescribe it. So it is a discussion you can have with your provider. Oftentimes we will prescribe it if the patients are really having a lot of side effects. They've tried the coconut oil, nothing is working, and it's making their quality of life negative. We will prescribe it. So it's an informed discussion that we have with the provider and the patient. But we can prescribe it. We do it in low dose, 2 to 3 times a week. It does require a prescription, and it comes in gels, creams, suppositories, rings, and tablets. Next slide. So I thought another funny little slide. Next slide. Treatment of dyspareunia, which is pain. Patients with pain secondary to radiation, surgery, which can cause scarring and shortening of the vagina. We oftentimes will recommend using a dilator on a schedule in addition to aggressive vaginal rehabilitation. This helps to widen and lengthen the vagina, which reduces pain over time and keeps the vagina open. So not only can you have sexual intercourse, but so we can examine you properly to make sure that there is no sign of cancer reoccurrence. So the dilator is not only important to prevent pain and to help with vaginal intercourse, it also helps to let us examine you. Daily exercises with a dilator of increasing size can be a difficult process, but it is an important process. By using pelvic floor exercises such as Kegels or working with a pelvic floor physical therapist, it can really help to improve your discomfort. Next slide. So the vaginal dilators, it gradually stretches the atrophic or shortened vagina. It retrains the body to gain control of those pelvic floor muscles and reduces inflammatory pelvic floor tightening due to anticipatory anxiety. It should be started about 2 to 4 weeks after radiation is complete. And you want to use a lubrication to help with the dilator. You insert it vaginally for 10 to 20 minutes, at least 3 times a week, but more is always better. It's not uncommon to have vaginal bleeding with the dilator use. And so to be aware that this may occur and not be afraid and scared by it. If you're getting too much discomfort from it, we may need to reduce sizes and go in a smaller dilator if need be. But using a pelvic floor physical therapist to help evaluate, demonstrate, and educate is a good way of helping to maximize your use of vaginal dilator along with allowing better tolerance of it. Next slide. Pelvic floor therapy improves and treats vaginal stenosis, pelvic pain, dyspareunia, bowel and bladder incontinence. The therapist, again, helps to train and contract the pelvic floor muscles to improve muscle flexibility. It's used as a preventative strategy to help reduce risk of developing pelvic floor muscle dysfunction in those who are just starting the therapy. Next slide. And then just picture, and then I just have my references on the last slide.
Hi, everybody. I'm Dr. Velez. It's really nice to meet all of you tonight. I am a reproductive urologist over at CINJ, and I take care of a lot of mostly men's health. So, you know, we talk a lot about fertility preservation, but for tonight, I'll focus mostly on the men's sexual health side of my practice. Next slide. So I'll run through I don't have to tell you guys this, the importance of survivorship and certainly some of the challenges that we face. But the bulk of my talk will be on penile rehab, the penile rehab program that I have here, and then some of the outcomes that we've seen in the literature and also in our practice. Next slide. So as you guys know, long-term survival following a diagnosis of cancer is really improving in developed nations, which is great. But living longer doesn't necessarily mean that we're living well. Next slide. all of the things that we do to treat cancer, pelvic surgeries or any surgeries, radiation, chemotherapy, different medications can really wreak havoc on our sexual health, our testosterone levels for men, and also fertility. And, I think it's a really sort of a disconnect. With male fertility, same as female fertility, we want to get into that clinic and talk to that patient at the same time as they're being diagnosed, because we're trying to sneak in and offer preservation strategies before they get any kind of treatment like chemo, radiation, or surgery. But sexual health is a little bit different. Some patients, it's not going to be a priority. And oftentimes patients really are overwhelmed. So it might not be something that we sneak in at the time of diagnosis, or maybe even immediately during treatment. But certainly offering options in parallel too, I think, is really important. Next slide. And that's really because sexuality and just general intimacy are significantly associated with health-related quality of life for all ages, even amongst the elderly. If we go to the next slide, you'll see that when we surveyed, I think it was 3,000 patients in France, these were all cancer patients ages 18 to 82. And more than half of them really suffered from substantial sexual health deterioration. If you look at that bottom graph, the orange and the brown bars are the men who had moderate to severe sexual health scores. And you'll see that there's a lot more of them in the older population, ages 52 to 82. And these are men who were reporting 5 years from their cancer diagnosis. And as you can imagine, the people who had the worst sexual health scores also had the worst rates of anxiety and depression. And, getting diagnosed with cancer can feed into that. All of the treatments we have can feed into that. And if your release is trying to be able to engage in sex or intimacy with your partner or just yourself, you can imagine how that would exacerbate those issues. I think the other really important part of this slide is that this paper looked at people with cancers all over the body. So this wasn't just prostate cancer or bladder cancer, which is what I think we typically think of when it comes to sexual health in men. These were men of all ages who had cancer of the skin. They had melanomas, they had non-Hodgkin's lymphomas, kidney cancer, thyroid cancer, colorectal cancers. So sexual health issues don't know an origin and they don't know an age. If you go to the next slide, I really think that the worst part about this paper was that 55% of those patients lacked any outlet to discuss their sexual health, which is really unfortunate. There are so many options for people to talk to. And I know here at CINJ, I see patients every Monday on the second floor. We don't have a dedicated sexual therapist or a pelvic floor PT necessarily, but I've been really lucky to help build some programs with local community sex therapists and community physical therapists who are excited to see our patients, male or female. And all of these symptoms or side effects or complications that you see on the screen, we have options for patients. Just because they come in with absolutely no sex drive doesn't mean that that's it, we're done. We have a lot of options for patients. Next slide. This is reeling it back in just to our post-prostatectomy people. So this was looking at a dedicated survivorship clinic. I think this one was from Sloan Kettering, but basically looking at outcomes for these patients. So the authors reviewed the EPIC sexual function scores for men before they instated their dedicated survivorship clinic and then afterwards. And when you compare the two, the men who were before are the red line on the left-hand side, and you can see how much worse those EPIC sexual function scores are compared to the men who were followed with a dedicated survivorship clinic. And that's probably because the men who had that dedicated clinic reported recovery almost to baseline sexual function up to 2 years after their prostatectomy, which is pretty incredible. Next slide. So that's really the purpose of there's multiple purposes to a penile rehabilitation clinic, but for me, a dedicated men's sexual health survivorship is maximizing the likelihood that a patient's going to get back to their pre-op erectile function level. While we're waiting for that recovery process, we want to maintain penis size. Because I tell patients all the time, there is nothing worse than going through all of this and finally getting back to having erections, however which way we get there, and then looking down and saying, oh my gosh, what happened to me? And then finally, while we're waiting for that long recovery process, giving patients the tools to have sexual activity if that's still a priority for them and their partner. Next slide. Just some of the pathophysiology. I mean, why are erections so vulnerable to all of our cancer treatments? And I think it's really because there's two main issues. One is that we can sometimes injure the amount of arterial inflow, so the amount of blood actually entering the penis, which we have a lot of treatment options for. I mean, Viagra, Cialis, intracorporeal injections, those are all great options. But the harder part of that to treat is actually the venous leak part. So not only do we have to get blood into the penis for an erection, but we have to trap it there. And having neural injuries, especially during like a prostatectomy or pelvic surgery, or even with radiation over time, that can lead to this trio of muscle apoptosis, increased collagen formation, and then endothelial damage. And the end result of that is really a tougher, fibrotic, not elastic penis, where we see venous leakage during the erection. So men coming in and saying, hey, I can get an erection, but I really can't maintain it anymore. As well as penile shortening. We'll look at that data in a few slides. And then also even sometimes curvature, abnormal curvature to the penis, which can be pretty distressing to patients. We call that Peyronie's disease. Next slide. So really, it comes down to a use it or lose it framework. I tell patients all the time, you know, when you were 25, you probably had 1 to 6 erections in the middle of the night and multiple throughout the day. And all of those erections basically meant that really highly oxygenated blood was surging into your penis and nourishing all of those tissues. So your penis was used to expanding and relaxing, and now it's not doing that. You know, after a prostatectomy, it could take 2 years to recover all the function that you're going to recover, during which time we see that penis, instead of expanding, contracting. Freeman et al. Looked at 100 patients who are post-radical prostatectomy, and they saw about an 8 to 9% drop in length and girth in the penis, which translated to about at least a centimeter loss in almost 50% of their patients, which can be pretty substantial for some of our patients. Next slide. And that's really a big reason why I say a sexual health collaborative for the patient where this is a priority. You know, I'm not talking about the couple that comes through and says, we haven't had sex in 20 years and we're not going to start now. That's fine. But I'm talking about our couples who are 50 to 90 who say, look, we like to be intimate, and a part of that intimacy is having an erection. We have a lot of options. And I love being able to see couples earlier than later. If you don't mind just clicking ×3, because I think I animated, I'm so sorry. I like to see them sooner than later so that we can establish a baseline and just know, where did we start? Because unfortunately, none of the things that we're going to do to treat your cancer are going to make you better. But we also like to set expectations. You know, again, it can take 2 years to regain your post-op, your pre-op erectile function. And then finally, while we're waiting for that recovery, try to protect anatomy just to keep things as normal as possible for patients. Next slide. There are a lot of things that we offer in these post-op visits. I am always talking to patients about vacuum pumps. Again, the pelvic floor PT, having several in my back pocket is integral to patient satisfaction and getting through some of these issues. Sexual health counseling as well. You know, it's, again, the mental toll, the emotional toll that this can take on a patient should not be understated, and also on their partner as well. You know, it can really, I just got off the phone with a sexual therapist this morning, just trying to understand like what their practice is versus mine. And we both came to the conclusion that, you know, a lot of times sex problems stem from relationship problems and vice versa. They really go hand in hand. A lot of my patients end up on some kind of a PDE5 inhibitor like Viagra or Cialis as part of their supportive therapy. But when that doesn't work, we can also offer gels or injections, and we even do a lot of penile prostheses, so inflatable and malleable implants. Next slide. In general, my baseline, like starting penile rehab program, is to start patients on Cialis 5 milligrams. It's a super low dose, very few side effects. And I try to have patients do this at least 5 days per week as like a maintenance dose. So basically, I tell patients, you know, you're probably not going to get an erection with the 5, and that's okay. We just want to force more blood down to the penis, bring more oxygen and nutrients, try to keep that tissue stretchy and healthy. But then 1 or 2 times per week, patients are encouraged to take a 20 milligrams. So that's our challenge dose. It's higher, it's the highest dose, and patients are much more likely to see erections after that. The reason why I like this protocol is because when we look back, we actually have good placebo-controlled trials on this. When we look back, this was again out of Sloan Kettering. Dr. Mulhall took patients on this regimen and then compared it to placebos or people who only did the Cialis 20 milligrams like once or twice per week. They had a 6-week washout period, and then everybody got Cialis 5 milligrams after I think like 9 months. Next slide. And what you'll see on the left-hand graph is that in the first 9 months, the people who were on the Cialis 5 milligrams daily had the highest sexual functioning scores. So that's great. We think it probably does help with some erectile function recovery. But after the washout period, and when you look at month 13, where everybody was on the Cialis 5, pretty much everybody is at the same place in terms of erectile function. Fine. But when you look at penile stretch length, the people who were on the Cialis 5 daily only lost 2 millimeters at the end of that first year. Compared to the men who were on nothing or just the once in a while Cialis 20, those guys lost up to 8 millimeters, almost a centimeter from their penile length. And that's only 1 year out from surgery. We know that this is a time-dependent process that can worsen over time. Next slide. Oh, sorry. Yep. Thanks. This busy slide is just sort of my brain pathway for how I think about penile rehab patients. So, we try them on the PDE5 inhibitors. I give them a couple of weeks to play around with it. And then if at the end of those 6 weeks, patients come back and say, look, like this isn't doing anything for me, I'll say, okay, you have an option. You can either keep going where you are, not a big deal, or if you want to substitute that challenge dose of 20 milligrams with an injection, that's when we start talking about injection training. If you go to the next slide, you'll see, the injections are just way more potent. Effectively, it's a direct path into the erectile tissue. I have patients learn how to do this in the office so that they feel comfortable. They know how and where to inject. They know exactly how to drop the medication. And then with that small test dose in the office, I can see how they respond so that way we can more safely titrate the medication at home. I know every commercial will say, if you take Viagra and you have an erection for more than 4 hours, it's an emergency. I've literally never seen it happen. But this happens all the time with the injection. So it is important that patients are much more careful, that they start low and move up to the right dose for them. And I usually tell patients, look, we know we're at the right place when you come back and you tell me I had a great erection for sex and it lasted me an orgasm. Or they come back and they say it lasted about an hour and then went down on its own. And that's really the sweet spot for these injections. There's a lot of medication combinations that can go in. I tend to start at Trimix because I really want it to work. I don't want to waste patients' time or cause pain for no reason. If we're going to put a needle in your penis, it had better work. Next slide. Of course, cost is always a major contributing factor. I am very grateful that we get to practice medicine in 2024 when we have options. Good RX coupons are great. So is the Mark Cuban pharmacy. You also have a lot of compounding pharmacies that have started to make these medications because oftentimes insurance will demand a prior auth. And then even after prior auth, insurance will say, cool, you can have 5 of these pills per month, which does us no good. So, Viagra at Costco is about $20 for 30 pills. With the GoodRx Gold membership, it's $5 for a monthly prescription. Trimix that the injection, I send it out through a compounding pharmacy in Michigan because they offer our patients a trial vial. Effectively, it's $50 for a tiny vial that'll probably last about 4 weeks. And it just gives the patients a fairly inexpensive way of giving it a try. If it doesn't work, they're only out $50 and maybe 2 or 3 injections. If it does, it's about $140 for a 4 cc supply. I added in Muse. It's an intraurethral gel as an option. Some patients have absolutely no interest in putting a needle in their penis, and I fully understand that. The gels, though, oftentimes are not as effective as the injection and cause worse burning. So it's rare that I actually prescribe it successfully. Next slide. And then just click one more time. I don't remember what I put on this one. Okay, yeah, so the vacuum pump. So basically, this is another reason why I like seeing patients early, because I break out the vacuum pump and everyone gives me this look of like, what do you want me to do with that? And I think it's really hard to get a patient who's already had surgery on their pelvis or radiation or chemo to invest mentally and physically in a vacuum pump. It's much easier for me to get them on board before they have any kind of treatments. But vacuum pumps are incredibly useful. We think that the actual stretching of the tissue is useful to maintain elasticity, but also the forcing of blood into the penis helps to mimic an erection, and it can really help to recover or at least maintain erectile function during treatment and while we're waiting for natural recovery. And not for nothing, a patient can always use a vacuum pump with a constriction band for sexual activity. It might not be as normal as their previous erection, but it is very effective. Next slide. We look at vacuum pumps in terms of, what has it done for patients, especially in terms of length loss. Kohler et al. Had looked at 28 men post-radical prostatectomy, and again, this is a time-dependent effect. He had some patients start their vacuum pumps as early as 6 weeks after their prostatectomy, versus I think it was 1 year later. And at 3 months post-prostatectomy, there was a significant protection of the penile length. And at 6 months, the people who used the vacuum pumps actually had improvement in their penile length, which was sustained after last follow-up at 18 months. So this is really a therapy that even for my patients who don't have cancer and are concerned about, diabetes causing erectile dysfunction, no erections for years, are concerned about length loss, I also recommend they use vacuum pumps before we get into the idea of doing implants. Next slide. Taken all together, penile rehab therapies with PDE5 inhibitors, injections, vacuum pumps, implants, the majority of patients who go through these therapies have a 3 times higher rate of erectile function improvement. And I think that's partially because they're plugged in with a provider that they hopefully trust and have a good relationship with. A lot of my patients will come through the door and say, wow, I can't believe I can talk to you about this. And I'll say, you're like the 30th person I've talked to about this all day. You're not the first one through my door. And I like to think that we're really lucky at CINJ because we have so many great nurses and social workers and front desk people who they normalize this. And also, it's people who will pick up the phone and say, hey, I understand you're having trouble with your medications. Let's talk about that. Or, hey, it didn't work. Okay, come on in, see Dr. Velez. She's going to talk to you about the next step if that's still something you want to pursue. Next slide. For all of the patients that we see at some point, we just can't get to a good erection with all the other medical options. And for those patients, I say, look, the last option I have for you is a penile prosthesis. It's surgery. It means a recovery process, but it's a surefire thing. You're not going to worry about, hey, I took this pill. I don't know if I'm going to get lucky tonight. And then there's a lot of stress and anxiety that can come into play there. Implants work. Their goal is just to get you a firm erection. They don't change what you think about with sex, what you feel during sex. If you left your prostate and seminal vesicles alone, then you're probably still going to ejaculate as well. They're just going to give you a reliably firm erection. Malleable implants are firm all the time, but they're bendy. So effectively, when patients are ready to have sex, they bend it up. And when they're not having sex, they tuck it in their waistband or they bend it down a leg. And that's what you see on the left-hand side. And then the bottom right is an inflatable implant. It's a little more complicated. There's usually 3 pieces to it that effectively when patients are ready to have sex, they feel for the pump that's inside their scrotum. They squeeze it a couple of times, and that cycles salt water effectively from the reservoir next to their bladder out into the cylinders that go inside their penis. The nice thing about both these implants is that they're very discreet. No one knows that they're there but the patient, even the malleables. Unless they're wearing a Speedo, they're going to look the same as if they didn't have one. Next slide. We already talked a little bit about sexual health counseling and partner support, so we can keep going. Again, so in conclusion, men going, especially radical prostatectomies, are at risk for sexual changes other than just erectile dysfunction. I didn't talk about it so much today because I know we're a little limited in time, but I see patients too for low sex drive, changes to their orgasm. Either they're, maybe they have premature ejaculation, or maybe they just can't get to an orgasm for whatever reason. And ejaculation, that can be really bothersome to patients. And even though we might not have a ton of options, at least we can talk about it and normalize it. Penile curvature, and also, again, changes in penile size. I think it's really important to try to see patients pre-op or at least early in their treatment pathway to establish their baseline and understand what their goals are. psychological and sexual counseling interventions are really important to help improve postoperative erectile function and sexual desire, and also orgasm. I think it can also be really helpful for strengthening relationships for patients between themselves and their caregivers or their partners. And finally, penile rehabilitation programs have been associated with preservation of penile length. It's always astounding to me how many patients come through and say, nobody told me this was a possibility, that I could lose this much. And how awful is that? With cancer, we lose a lot of organs. We can lose a lot of dignity. These patients don't have to lose their sexual health and penises too.
Okay, well, I would like to just say thank you to all of our presenters, Joan, the social work team, Valerie, Dr. Velez. Thank you everyone for such an informative